Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Two presentations and three presenters. I'll introduce actually all three presenters right now. The first presentation will be by Dr. Kumanan Wilson. Dr. Kumanan Wilson's research focuses on digital health, health data, immunization, pandemic preparedness, and public health policy and innovation. He's the co-founder of Can Immunize Incorporated, a science-based technology company specializing in immunization software. I'll also say that he is the CEO and Chief Scientific Officer of the Briere Health Research Institute. He's a professor and Department of Medicine Distinguished Clinical Research Chair in Digital Health Information. Our second presentation will be by Dr. Farhad Motamedi and Dr. Gary Viner. Dr. Motamedi completed his family medicine residency training in 2003 at the Civic Academic Unit. He joined the same site as a full-time academic in 2008, and since then he's assumed several leadership roles, including the unit postgrad director from 2009 to 2015, and the unit medical director from 2016 to 2023. He's currently the chair of the Ottawa Hospital Family Practice Plan and president of the Ottawa Hospital Academic Family Medicine Associates. He'll be joined by Dr. Gary Viner, who completed his family medicine residency in 1980 and began as a family practice physician in Ottawa and provided comprehensive care, including obstetrics, for over 36 years. He began teaching medical students in 82 and became a community resident preceptor in 91. In 2001, he joined the Civic as a full-time academic and transitioned to academic medicine. After earning a master's in education in 2010, he established a national reputation in medical education research and served as the department's director of evaluation until 2019. Though now he's retired from clinical practice, Dr. Viner continues to provide clinical supervision and contributes to research at the Civic and Riverside teaching units. There we go. So we're in for a treat today. So Kumanan, I'm going to hand things over to you, and please share your screen, and the floor is yours.
Great. Well, thanks for having me, inviting me to speak with you today. I know this is an issue a lot of family doctors have to deal with. It's something I've been studying for basically the majority of my career, and honestly, it's been frustrating to watch the train wreck unfold. So vaccination policy, what went wrong? This slide sort of epitomizes what went wrong. For too long in this process, people have been shouting at each other as opposed to trying to find constructive engagement. And the hard truth is we lost measles elimination status in Canada, and the US is now run by anti-vaxxers. So we need to do things differently, and I'm hoping to speak with as many people as possible about what's a new way forward. So the objectives are to understand the factors behind the rise of vaccine hesitancy and anti-vaccine sentiment, but not to do it in a simplistic way like misinformation and such, but what's the psychological dynamics here? And then to provide guidance with this understanding on how to navigate vaccine hesitancy at the clinical and policy levels. So, I mean, first of all, I don't need to tell you this, but vaccines are the second most effective way of reducing morbidity and mortality in the world after clean water. This was from Nature, 93 million deaths from measles. Everything but that little dark brown thing is children under the age of 5. So, this is an incredible intervention that saves children's lives. And oops. Are you seeing this drop down menu at the top? No, just seeing my screen. Okay, great. Unfortunately, we've known for a while that vaccine hesitancy is a problem. This was in 2019, the WHO identified the emergence of vaccine hesitancy as actually a top global threat. And now we've seen it come full circle. RFK is in charge of this US health system. He's eliminated the ACIP, American College of Immunization practice, and replaced it with anti-vaxxers. Basically, I'm hearing from people down there. They basically created a shadow organization, the vaccine community, to do the oversight and provide accurate information. mRNA vax support has been shut off, research in that area, and I think they're going to add in autism as a vaccine adverse event that's compensable by the vaccine courts. Also, they believe Tylenol causes autism. So, this is unfortunately the reality of the situation we're in. But, we can be smug here in Canada, but we actually have more cases per capita of measles than the US. And we will probably be responsible for the Western Hemisphere losing its measles elimination status. And this was an article in The Guardian pointing this out, right? We are the epicenter of the measles outbreaks, in Alberta is the same thing. And we recognize this in specific religious communities, but this has emerged because of distrust that occurred during the pandemic. So my journey in this area came when I helped set up the research program at the Canadian College of Naturopathic Medicine way back in the day. And I have to give them credit. They were very open to studying this and engaging on this matter. And it's sort of a model I think we need to follow moving forward. So I didn't realize that people didn't believe in vaccines. When going to med school, I thought everybody believed in vaccines. It was a surprise to me that there were concerns about vaccines. And working at the Naturopathic College, I was hearing concerns that some people didn't believe in vaccines, and they were suggesting alternatives to vaccines. So I thought it'd be worth studying this. So one of the first studies, and you can see this is back in 2004 we did, was just looking at the attitudes towards pediatric vaccinations among Canadian naturopathic students. And this was cross-sectional. We didn't follow a cohort over 4 years, but we found generally the trust in public health information declined as you went through the program, as its support for vaccination. And coincidentally, at the same time, the Chiropractic College published in CMAJ a very similar paper showing the exact same thing. And when we talk to the Naturopathic College, they don't teach anything about vaccines in the college. So it's not because they're being taught anti-vaccine information. Another phenomenon was happening. But then I had an idea. I'm really smart. I can solve this anti-vaccine problem. I know how to fix this. So I said, well, obviously they aren't seeing the disease. If they saw the disease, they would understand how important it is to get vaccinated. So we went to the March of Dimes and we got a polio survivor, and we did a randomized trial of the fourth-year students, the most anti-vax students, the most vaccine-hesitant students, and we randomized them to a presentation from me showing the epidemiological benefits of the polio vaccine, how over time we've virtually eliminated the disease. And then we had the polio survivor, Marcia Dimes, come in and talk about her life and what it's been like, and purely anecdotal storytelling of the struggle she's had and how amazing it is that nobody else has to go through this. So what do you expect we found? I know this isn't an audience normally. I think most people would expect that the polio survivor group would have had the most impact on them from the presentation. So we actually found that 25% were less likely to advise vaccination after hearing the polio survivor. And not only that, they complained to the dean of the college, saying this is a manipulative study, that we didn't provide both sides. We didn't talk about the negative side effects of the vaccines. And this was eye-opening to me. We're dealing with issues of identity here for many of these people, and going in and directly confronting them with sort of a smug attitude that I'm smarter than you, you need to just listen to me, I'm a doctor, or whatever, isn't going to work. It's like walking into a religious institution and saying your religion is wrong. And this is a religious belief for many of these people. This is part of their core identity. And the question is, what's actually happening here? And this is sort of what I think is the dynamic. People with alternative belief systems are often rejected. They're ridiculed by the community they're in because they are alternative belief systems. They feel rejected. They don't feel they have a voice. Then they end up in places where others share those belief systems, and alternative medical schools, alternative schools like naturopathic medicine are examples of those. And then they hear from others that actually you may have been right all along, and that reinforces their belief, and it actually makes them angry. One of the things they hated was being referred, that their ideas were crazy. And this reinforces the belief system. They develop really a strong confidence in those belief systems, and it makes it very hard to challenge. It becomes part of their identity. And then we have this other dynamic of, those are the extremes, and I'd argue public health is another extreme. But, a parent who just had a newborn and had a lot of things to deal with is hearing all of this knowledge, all of this stuff hitting them, and they're confused. And they can be swayed either way. And it really is a delicate process of how we manage that parent, because if they have any inclination towards vaccine hesitancy, we can lose them if we don't handle it carefully. So what had happened geographically in alternative medical environments started to happen virtually. And we know the anti-vaccination communities on the web, and early on, 40%, this is in 2002, of the websites that had to do with vaccine were anti-vaccine. And you got to give the anti-vaccine community credit. They've been far more innovative than the pro-vaccine community. They figured out the new technologies and how to leverage them well in advance of public health. And we actually found that out when we did our study. So I had a colleague of mine was telling me all these crazy anti-vax theories, and I just said, I'm not going to call anything crazy, but and I said, where are you getting this information from? So she said, I just go on YouTube. They just post them there. And so this was actually the first study ever published on social media and anti-vaccination attitudes. And what we found, this is again 2007, was that the majority of the video, only a very small percent, like 25%, I think, were supportive of vaccines. Many were ambiguous, and a lot were anti-vaccine. But the anti-vaccine videos had more comments, a higher rating, and a lot of engagement. And they also took a lot of effort in curating them. And at that time, the public health videos were just boring. Like, they were bland, sort of infomercial style stuff. And here's one example of a woman who said she lost all her limbs from the flu vaccine. And you can see from these comments, people were pretty amped up. It's time for the CDC to admit the truth, to help these kids. Thanks for making this. We will get these people. And when I talked to public health about this, they said, "Oh, it's a small minority. Don't worry about it. These are just the fringe." But again, the CDC is now run by RFK, so that was obviously an oversight with serious consequences. We actually mapped this out. I got a computer scientist, and you can see essentially we were creating virtual communities talking to each other on the web. So this is the echo chamber phenomenon that everybody talks about. We were able to demonstrate it through linking the comments that people were just using this as a way to find their community. And now this is YouTube. This was before Facebook. We actually did a study on MySpace. That shows you how long this was. We went on Second Life, found similar kind of, we had anti-vax sites on Second Life, which was the virtual world. So they were finding ways to speak to each other. And we're really seeing this now come to a head just society-wide with the emergence of populism. And we can't ignore this. I know people may not like it, but it exists, and we live in a world where populism exists. And it really affected us during the pandemic. We wrote a couple of papers about this, about the impact of populist sentiment on the public health response during the pandemic. And of course, it manifested in the trucker protests, which we had to deal with here. And I actually went down and I chatted with the truckers at one point just to hear them out and hear what their perspective was. And I really do think one of the big mistakes we had was early on when our prime minister at the time said he would not talk to these people. I think that does not help move the conversation forward on these matters. And people end up more ingrained in their viewpoints. Whether you can sway them or not, you can't, but you can at least engage with them. So, with all of this information, I just want to check my time here. How do we deal with this? And essentially, we have to figure out how to positively move this confused parent towards pro-vaccine sentiment and not alienate them in the process. Because I know it's changed and I know it really has improved, but in the past, there was a bit of a reactance and confrontational approach to some of these parents. And I understand why. Like, you believe strongly in something. And we've got to remember that same dynamic I talked about with the naturopathic students happens with us. We believe strongly in something. We believe it saves the children's life, and someone's telling us we're wrong. We're going to get actually even more ingrained in our opinion. So we have to realize that psychological process is going on in our heads. So obviously this is about trust, and how do we establish trust, and transparency and reciprocity are probably, the keys to doing that in the long run. So we can win in the short run with mandates, and that's been proven. We can increase vaccination rates through mandates, but ultimately they can be counterproductive and lead to even more resentment. And I think we saw the manifestations of that during the pandemic. So at the clinical level, and I know this isn't happening anymore, but this was happening back in 2005, there was this phenomenon of family doctors who were dismissing families that refused all vaccination, and they would 28%. This is in Archive of Pediatric and Adolescent Medicine, which is now JAMA Pediatrics. 28% of pediatricians say they would fire a family that agreed to some vaccination but refused one or more other vaccinations. And I don't need to tell anybody here, this makes no sense. The child didn't make that decision, so why are you punishing the child? It's like, a child is being abused, and why? Well, okay, we're not going to help you out. It assumed that vaccination is the only important thing you do for the family, and obviously that's not the case. You do so many great things for a family beyond vaccination. These are exactly who you need to be followed. I understand if you have other immune compromised patients in your clinic and such, there's a risk, but there's ways to deal with it. And particularly now we can deal with these people virtually. But more importantly, if you ever want to get that child vaccinated in the future, is to just show the parent that you still, are going to look after them, and then revisit it a year later. And then somebody, I think Scott Halpern wrote about this. Early on, you can figure out if it's worth having the conversation or not. And if it's not worth having the conversation, say, we will revisit this later, but we're going to continue to care for you and your family. I know this dynamic has changed, but this was a phenomenon way back. And it was also a phenomenon in the mentality of public health way back, this very, very sort of aggressive approach, a power approach, actually. So we wrote this paper back in 2007 for a Canadian Family Physician and how to preserve relationships with anti-vaccine parents. And this is not empirical. This is based on theory, social psychology theory. And I will try to, we essentially looked at what's the psychological dynamic and how do we counter this? So you just briefly, for the issue of naive realism, we have to understand what parents are saying when they raise the issue of vaccination. And some of them aren't anti-vaccine. Some of them are just confused. And we can sometimes rapidly just get upset and say, oh, you're anti-vaccine, you're one of them. And particularly if you had dealt with just 5 more parents right before that, like who've been like that. It's just natural. And that's why they say some people are suggesting chatbots may be a better way to deal with this. Reactance is, I think, the biggest issue. And that's the dynamic I was talking about, that don't let it emotionally bother you. I know it's hard to do, but it's important to do that. And don't let your decision about vaccination escalate into an argument that could taint future interaction with the parents. Maintain a positive relationship with all families. Explain your behavior in a way that are consistent with their prior experiences with you. And make sure you understand that you're sincerely concerned about the children's health and welfare. And I realize this is now part of the way family medicine addresses things, but I also appreciate this is hard to do when these people can be very aggressive. I've dealt with them. I've spoken to them over the years. And it's important to just shut it down before it escalates, because they can be very personal sometimes about what they say. So this dynamic at the clinical level is happening at the policy level, and we're there's reactance at the policy level, and I understand why. I mean, they're sometimes calling for the deaths of these officials and imprisonment, but we and it's hard to overlook that. But the best way to do this is I think to triangulate and take away their best arguments. And we actually haven't done a good job of that. So in the US, it's standard. Everybody gets a vaccine information sheet. There's informed consent for all vaccines. We were the last country in the G7 to bring in a vaccine injury compensation program, and we did a poor job of it. 45 other countries had one before we finally decided to bring it in, and we didn't tell anybody about it. Our adverse event reporting systems are not up to the standards of other countries. So there's validity into what some of our vaccine hesitant people are saying. But I think perhaps the simplest thing is, a lot of parents just, it's not that they're anti-vaccine. This, as you know, in family medicine, they don't have access. And we can just, instead of focusing on fighting those who we can really convert, we can just make it easier for everybody else. And there may be people in communities who just want to quietly get vaccinated because they don't want to get alienated by their community. And if we can make it as easy as possible for them. So this is boring talking about logistics, but as you know, 25% of Ontarians don't have a family doctor. It's going to be kind of hard for them to get their kids vaccinated. And I think it's important to listen to criticism. If you look at the vaccines that have been the focus of the anti-vaccine sentiment, they're all the reactogenic ones. And they overhype stuff, but the oral polio vaccine had a rare risk of vaccine-associated paralytic polio. They don't complain about the inactive one because it doesn't have that. The wholesale pertussis was reactogenic with febrile seizures. Not a lot of people complaining about the acellular pertussis, and there were problems with the COVID vaccine. I mean, that's the reality, and it didn't provide sterilizing immunity. So, I think, listening to these concerns, recognizing they're probably being blown out of proportion, but there could be a signal in there that warrants further examination, I think is important. This is sort of in that Guardian article, I sort of said that we need to find champions in these communities. And I think that's what Ontario did with the Mennonite community who believe in what public health people are telling them and then can communicate that message. That's a whole lot easier than us coming in as a foreigner, so to speak. And this idea, which I know we're moving away from, but it had this impact of shaming people, is not working. And so just to finalize, finish up here, I think we just need to do things differently. It's urgent. The world has clearly changed. We live in a world where populism and information is being communicated in different ways, and we're going to have to adapt to that world. Thank you.
Kumanan, thank you so much for all that background around vaccine hesitancy and suggestions for ways moving forward. So thank you very much. And I can see that we're going to have lots of questions here for you. So I see Gary's actually got the first one. Go ahead.
The biggest issue is we are hearing amplification of the vaccine risks without adequate representation of the vaccine benefits to properly put this into perspective for society. And we also are not spending any time talking about how to improve that safety. These things would make a big difference, I think, to people. If we just sort of accept the status quo, then we're not doing a good enough job, because we do know there's risks. We state them, but then we minimize and deny them. And so we're not responding to their biggest and fundamental concerns.
Yeah, so I think there's been a paternalism that's sort of governed how we've done this before. So when I've been fighting for this vaccine injury compensation program for 10 to 15 years and just getting rejected by public health officials who said, well, we're going to make people scared about vaccines if we bring it in, with no evidence to support that. And the fact is, like I said, Vietnam and Bangladesh had programs before Canada did. Like it was getting ridiculous. And even at the end, they still weren't going to bring it in, and then we weren't going to get a vaccine if we didn't bring it in. The manufacturers, even though they were indemnified, said it's the only ethical thing to do. But that's sort of emblematic of, they didn't trust us to be able to handle the complexity of the information. And it just made things worse, because there were side effects of the COVID vaccine. We know that. And they were dose, the myocarditis risk was significant until they reduced the dose with the Moderna vaccine. And VIT was obviously a major issue that pulled the AstraZeneca vaccine. So, and then there was this overemphasis on herd immunity when we found out it didn't actually provide sterilizing immunity. So, I agree with you. I think that we overemphasize the benefits, underemphasize the risk, but the benefits are still very real for these vaccines. And I think most people can deal with it if you give them the honest truths. And the article in Science showing these chatbots talking to people about difficult issues like climate change, like vaccines, and they do a better job of bringing people to a middle ground than we do, because we're human. And we react, and it's hard to just sit it out for a while with these people and go through everything.
Thank you. Ben, go ahead.
Thank you. This is great. What we do at Pearly Health for staff who prefer not to be vaccinated is we have them sign forms similar to the consent form. So one way or the other, they are consenting or dissenting, but they're actually acknowledging the dissent. And we make it as easy as possible for staff to get vaccinated. And I think that's important for people in the community as well. And we run into supply issues in September and October for flu vaccines, as an example, where people are coming in and they're asking about the flu shot. And I understand the logistics. You have to have, you can't get it all done by September, but that's one of the barriers that we note. I agree that acknowledging the side effects is very, very important. And maybe emphasizing that the side effects are proof that the vaccine is actually working, right?
We use the Buckley's analogy there, it tastes horrible, but it works. And we've actually found when they remove the reactogenicity, they remove the effectiveness. And so the whole cell, acellular is not as effective as the whole cell. Like if there's an outbreak of polio, we go back to the oral polio vaccine. When they reduce the dose of the Moderna mRNA vaccine, it wasn't as effective. It's actually why we add adjuvants into vaccines. They clean them up too much. So I agree with you. That's an important point. Like the measles vaccine is reactogenic. Like 1 in 150 people will end up with a measles reaction, as you know, a week later. So
I think also telling people, look, we're giving you something that's going to make you, that's going to make your body think it's fighting an infection, so that should you come down with a real infection, you'll already be prepared. So if you're tired or fatigued next week, don't be surprised. That's the vaccine working, right? The other thing as well,
informed declination approach is a good approach.
yeah. The other thing as well is, this is my practice. I ask people to sort of let me know where their sources are, sources of information. And I actually demonstrate on the computer what happens with your search results if you go into incognito mode. And I tell them that, the search engines are calling the clicks that you're doing. They're following you and give you the information that you've been following already. But if you go into incognito mode, now you'll get a new source of information using the same search words.
That's interesting.
Yeah. And then finally, I only have one family who's sort of, it's a belief thing. I just acknowledge that, okay. But, as a doctor, every time you come in, I will be promoting vaccines. Don't take it the hard way. I have to do this, it's part of my job, so that I don't alienate them, because sometimes they also have different beliefs about other treatment options, right? Not just vaccines. So these are some of the things I found have worked. I don't know, but I love the presentation. It sort of consolidated what I'd already sort of felt. It was good.
So no, great. Thanks for that. I'm going to take some of those points with me.
Okay, well, thank you very much, Kumanan, for that presentation and for these questions. So with that, we'll now move to our second presentation by Gary and Farhad. So I'll hand things over to you.
All right, thank you very much. So hold on, let me advance. Okay, so I'll be talking about a study that we did looking at the impact of electronic health record use on patient-centeredness in virtual encounters. I have to say this is really the lead on this study is Gary Viner, who's here. I'll be presenting it, but he'll be helping with in the question period, right? It was a multi-center study. So from Ottawa, we had Doug Archibald, Kendall Noel, who I don't think is online, and then Laura Santos, who was a resident of ours. And we had a group from UVic, so in Victoria. We had Helen Monkman and Andrew Kushner for a PhD, and Lisa Shaw was a PhD candidate who worked very hard on this study with us. We did receive a prime grant for our study, so thank you, DFM, for that. So that's really our only disclosure. Okay. So, I mean, we all know that electronic health records are used in pretty much all family medicine and hospital settings nowadays. As of 2022, and the stats were around 93% of primary care physicians in Canada were using electronic health records. And yet there's not too much of a focus on electronic health records in the education settings for our med students, residents, or even in physician trainings in CMEs or whatnot, other than just learning to use the particular EMR that you have in your practice and the tools that are available in terms of its functionality. And yet there is already evidence that demonstrates that interaction with electronic health records do impact both physician-patient communication and also physician-clinician clinical reasoning. And so in, I think it was 2018, sorry, that's the background of that, sorry. Yeah, in addition to that, with COVID, virtual care became a more prominent component of the patient-patient encounters. And prior to 2019, we were looking at about 10 to 20% of visits being in virtual care. And by 2020, that was 60% of visits. And afterwards, the stats around 2021 were around 40%. Of these, about 20% were virtual care that was done by video conferencing as opposed to telephone. And that's the latest stats that we had available to us. So when the Ottawa Hospital and the academic health teams that were associated with it, so the Civic and the Riverside transitioned to Epic as our new electronic health records. It was a much more powerful tool than the previous one that we had, with a lot of templates and sort of AI features. And so we were wondering about how that's going to impact the development of clinical reasoning in our learners. And so we had thought about a study to look at the differences between novice residents and experienced physicians in terms of impact of electronic health records on clinical reasoning. We had two academic units, Riverside and Civic, who use the same electronic health record, so we figured that's the perfect setup for that. We would use simulated patients and SU scenarios to look at this. But then COVID happened, and so we had to think on our feet and adapt our study to the new realities of COVID. And so we had to shift to the virtual format, and simultaneously, we decided to switch to looking at patient-centeredness. And so in the end, we ended up having 10 residents and 6 staff physicians enrolled. And we had each of them do 2 SU scenarios with different standardized patients sequentially. And so overall, we had 32 encounters that we could look at. The sessions were virtual by Zoom and recorded and auto-transcribed and then manually corrected. The recordings of the sessions were then analyzed for patient-centeredness, clinical performance, and also the use of the electronic health records. The tools we used to do that was basically the SU exam scoring, which is already designed to look at patient-centeredness as well as the clinical performance. We also used the patient perception of patient-centeredness, which was completed by the standardized patients, and also a modified version for the self-perceived patient-centeredness to be completed by the participants. There were also interviews that were held after each session to ask about patient-centeredness. There were some additional tools, like we used the NASA TLX questionnaire to have the participants rate sort of their perceived workload during the task. So the instructions that were given to the participants included the fact that we were going to use a trained actor as a standardized patient and that we were using SU scenarios. We told them that historical info might be available in the electronic health record that they're using, and that this is a new patient to their practice, that they were to use the electronic health record to document each encounter, that they would have a time limit of 20 minutes with the simulated patient and 5 minutes to complete the documentation afterwards. We also explained to them that the setup was in the training environment of our electronic health record, so in our case called the EPIC sandbox. And so any templates, smart phrases, or other customizations that they may have in place in the real environment would not be available to them in this training environment. So in terms of the results, there was quite a bit of variation in the electronic health record used by participants. We had one staff physician that didn't use the electronic health record at all while they were with the standardized patient. We also saw that the 11 of the 32 encounters, only one section of the electronic health record was used, so from primarily the progress note section. The page count, which looks at how many different pages are used, varied from 0 to 11, and the navigation count, which looks at how often the physician would navigate from one page to another, varied greatly between 0 to 123. Only 10 out of the 16 participants attempted to retrieve past medical history reports for the standard patient or the case that had reports in the electronic health record. And the majority of people did not actually order labs or imaging using the electronic health records. Of those who did, 4 of them did it while the standardized patient was still present, and so in 4 encounters was done while they were present, and in 4 encounters was done after the standard patient had left during the 5 minutes of documentation that they had. So this is how it looks on EPIC. So basically each of these tabs would be considered a different page, and so the progress note page was the one that was used. And as I mentioned, 1% didn't use the EHR at all. But the majority of people only clicked on the progress notes, as we mentioned. As well, in terms of retrieving the information, there was some imaging for one of the cases, and these had been scanned in the media section. And the residents had a lot of difficulty finding this, whereas the physicians were more familiar with the fact that any imaging done outside of 2H ends up scanned into media, and so that was less of an issue. And we did see that the patient-centeredness scores would go down the more the participants would attempt to navigate the electronic health record and complete some of the more complex tasks. We did a qualitative analysis looking at the video for non-verbal signs of stress and cognitive loading. So these would be things like touching of the face, head and neck, or adjusting glasses or whatnot. And interestingly, the proportion of time spent using the electronic health record or internet would correlate with the proportion of time that they spent using these nonverbal signs of cognitive load or stress. So the more they were using the technology, the more stressed they seemed to be, or perhaps vice versa. As well, the scores for patient-centeredness or the survey results for patient-centeredness and the SU scores tended to decrease as the proportion of time displaying these nonverbal signs of stress increased. And these graphs show that with looking at each case separately, and then the staff physicians being sort of in green and the residents in red, both cases. We also saw that there was a significant difference between residents and staff physicians' patient-centeredness scores, which I guess we would have hypothesized that going into it, but it panned out in our study. And only for the residents, we did find a strong negative statistically significant correlation between the time they spent actively using the electronic health record and their patient-centeredness score, meaning the more time they spent, the worse their patient-centeredness score seemed to be. These graphs here look at the patient-centeredness scores by number of electronic health record pages that they access, or by navigation count, which is again how often you would flip from one page to another. There was a negative trend there, but the relationship wasn't statistically significant. We did have a number of technical challenges in the analysis of our data. First off, there was a variability in the time stamp on the Zoom encounter and Zoom transcripts, so that affected the appointment lengths and time counts. As well, the Zoom-generated transcription wasn't ideal, so non-lexical conversational sounds like those sounds weren't captured very well and were problematic. Filler words like okay, so, perfect, whatnot, were mumbled often and repeatedly by participants, especially when they were multitasking in speaking and using the electronic health records at the same time. And of course, the Zoom-generated transcription always has difficulty distinguishing speakers when the participant and the patient would speak at the same time. So there was a lot of manual correction that needed to be done in reviewing these videos. That was done by Lisa Shaw, so she spent a lot of time doing that. The resolution of some of the encounters weren't great, and there was also a lag of audio compared to video. So there were some problems in trying to analyze these videos afterwards. There were some Zoom-related challenges. So some of the participants didn't seem to hear the time prompt that was given by the research assistant who was observing the encounter. And so the time range and the time spent with a standardized patient varied greatly from 10 to 33 minutes. The acting of one of the standardized patients was unfortunately inconsistent. The actors were supervised once during a dry run as a training, and then because of COVID, there wasn't much supervision after that. And it's only when we were viewing the videos for scoring that we saw that one of the standardized patients was very inconsistent in how to respond to prompts or questions and whatnot. Also, the instructions to the participants didn't seem to be interpreted properly by everyone. And so most of the participants didn't actually attempt to order investigations or do any referrals, as we had discussed earlier, even though that was part of the instruction. So if a similar study were to be done in the future, clear instructions for the participants would be recommended, specifically focusing on whether they should be ordering tests, referrals or not. It would probably be also better to use a screen recording software to capture keyboard and mouse activity, and that would make it simpler to calculate the time spent actively using the electronic health record. Training of the standards patients can also be improved, and they should probably be supervised more closely. Also, some of the scenarios, scenarios lend themselves better to Zoom encounters than others. So we had picked our scenarios initially with the intention of doing the study in person, and so using scenarios that are better adapted for Zoom encounters might be better. So there is certainly some implication in terms of resident education. There's been many studies that have suggested that some video communication best practices should be added to our medical student and resident physician training, including things like looking at the camera as opposed to the screen, the length of pauses after statements, making sure that speaking at the same time as the patient, using clear language, active listening, that kind of thing. And so perhaps having a digital communication curriculum added to our curriculum might be helpful in that regard. Also, some focus on patient-centeredness while using electronic health records might be helpful. So our conclusion was that the resident physician patient-centeredness and overall clinical performance scores were negatively impacted by the use of electronic health records to a greater extent than what we see with staff physicians. And so it becomes even more important in the training environment to focus on that and have formal instructions around how to maintain patient-centeredness while you're still using electronic health records. As well, perhaps updating our assessment tools. The SU is the primary assessment tool that we use for assessing patient-centeredness at the end of residency, and perhaps adapting that to include the use of electronic health records might be a better assessment as to how they're actually going to function when they're going to be in practice. And certainly further studies in these areas would be helpful. So these are references quickly, and that's it. So thank you very much for listening. Just going to stop sharing. All right.
Great. Farhad, thank you so much. That was a great summary, great presentation. Really appreciate that. I think with this study, certainly we've realized the challenges of trying to control aspects in a study, especially in an education environment. This is hard to do. Yeah, it's very context specific, but I think sort of these general trends, I think, were confirmatory for us in the study. The more time distracted on a screen, less time there is for a patient-centeredness. So anyways, I'll open the floor here for comments and questions.
I will say to you in response to your comment, Doug, while we're waiting to see if there's any questions. Yeah, we learned a lot on the study of things not to do or do differently. So yes, there was, and I think the adapting to the COVID pandemic and virtual environments, obviously we were very new to that. And so the use of Zoom and how to capture things appropriately, as I mentioned in the presentation. I think a lot of the tool can actually be used very effectively to capture many things that you might not be able to capture in a face-to-face encounter. And so there's certainly some advantages there that going forward we would be able to use more.
And perhaps I'll jump in and also say that I thought we had a really great team who was very dedicated to this project, and it was complicated by the unexpected occurrence of the pandemic. And the other thing that I'd comment on is our team in Victoria, who were all human factors based specialists, are unable to join us today because of the time zone difference. They were invited to join us, but it's 5 o'clock. Well, I guess turning almost 6 o'clock in the morning there. So it's a little bit hard for them to participate. So they're not here. But thank you very much, Farhad, for a fantastic summary of the work we've done.
Thank you.
Well, people are thinking about this. Something that I was just thinking about as you're presenting, Farhad, and that is looking at other means of assessing patient-centeredness. As you mentioned, SUs tend to be our primary assessment for this. But any further thought onto what we can be doing to improve patient-centeredness?
Yeah, I mean, the most effective one is when we're actually watching people with patients. So not necessarily as the final assessment, but during the formative assessments that we're doing all the time. That's obviously the most realistic one and the most effective one. But as an exam, I know Sue has a lot of as detractors, but I actually think the SU exam is not a bad one. It does assess some very useful tools in terms of patient-centeredness, but it is outdated. And I do think that looking at how that changes when we're actually having to document at the same time as seeing the patients would be more realistic. But how to do that is a good question, and I don't have a great answer for it. It's difficult. The other thing I would add is that even as we did this study very recently, the landscape has changed quite a bit. And as the AI scribes are becoming more and more common, that changes things quite a bit too. So it'll be interesting to see whether the impact on patient-centeredness is reduced by use of AI scribes. I mean, that's the whole selling point of it, other than saving us time, is the fact that it frees us from having to look at the screen and allows us to look at the patient and get back to how things, I guess, were intended to be or used to be, and whether the patient experience is improved through that, and whether that's captured in tools that are used to assess patient-centeredness.
I'm seeing Ben's question about the thoughts of a post-visit survey. And just to be clear, Ben, I'm not sure if you're talking about this on a routine basis or if you're talking about this in the setting of a research study. So can you clarify your question?
Just on a routine basis, but and random, right? So you're not sort of questioning everybody. But in the context of a study longitudinally, I could see how that could be used as well. So you can see trends, and maybe there's times of day, maybe there's specific offices where patients actually feel different. It's just that whenever we talk about patient-centeredness, I always think, well, what does the patient think?
Yeah, a number of years ago, Eric Waterton did something like that at our center. Basically, we would have these paper questionnaires that were handed out to patients, seeing our different residents, and we were trying to capture data on all residents at the Civic and see if what the patients felt correlated with what the supervisor was seeing in terms of which residents seemed to have some difficulty in that area or not. Unfortunately, I don't think he's on the line here, so I'm not too sure exactly what happened with that, whether it ended up being published or presented. I don't know if you remember, Gary.
I was going to comment on the same, and I know that, at that point I was director of evaluation, I think. I remember we looked at this particularly for some problem residents, but I don't remember there was any publication of it.
Yeah.
I don't think it ever went to that point.
I
And
think the
just
idea is very,
incidentally,
yeah.
I was just going to say that we just submitted an article for publication just last month on this study.
It would be cool to reconcile what the supervisor sees and what the patient sees, and if they're closely associated, then I mean that's worthwhile to know.
Yeah. Don't quote me on it, but from what I recall, it did correlate with what the supervisor were seeing. I don't remember any big surprises or anything like that from the results we got from the patients.
I seem to recall that we were using this as a tool when we were concerned about some of our more challenging residents who had some weaknesses, and it was used as evidence to help support the evaluation. But as I said, I don't remember what ended up happening beyond that.
Yeah, specifically the problem that we're trying to address there was the residents who were resistant to feedback. And so to show them that, look, it's not just me saying that, the patients who are seeing you are saying the same thing. So that was kind of what got us started on that.
Oh, Gary, Farhad, thank you so much for this presentation. Very much appreciated. And also like to thank Kumanan, I think he's just left, for his presentation as well. And I encourage you all, please, to fill in our session surveys. This is important for accreditation purposes, so please do. And also like to draw your attention to next month's Family Medicine Grand Rounds. And you can see the speakers on the screen. So with that, I wish you a good day and look forward to seeing you again in November.